first we are going to finish up general microbiology. We still have like one page left. And we are going to start with a new topic, which is basically bacteriology. So the last thing we spoke about, if you remember, we spoke about different types of exotoxins, and we also discussed superficially the endotoxins. But today I'm going to be more deep regarding the endotoxins and why they are bad. To start with, are endotoxins in gram positive or gram negative, guys? Endotoxins. They are in gram negative. This is correct. So lipopolysaccharide found in the outer membrane of the gram negative bacteria, both Cocci and Rod. This lipopolysaccharide, we call it endotoxins. It is composed of O antigen, corpolysaccharide, and lipid A, which is the toxic component. So the lipid A is actually the toxic component. So lipopolysaccharide, you need to know how it looks like. You don't have to memorize everything in the structure, but you just need to know that it has like a lipid A, carbohydrate, and O antigen. So let's take a look at this. So as you can see, it has the O antigen, corpolysaccharide, and lipid A. So the lipid A is the problem. He is the one leading to the symptoms. Yeah? So if you take a look here, lipid A is the toxic component. So it's released upon cell lysis. Why cell lysis? Because as we said yesterday, the lipopolysaccharide are integrated within the cellular wall of the bacteria. So it will be released into the circulation. Now I have a question. Can we have immunity against endotoxin? Yes or no? Can we have formation of a mature immunity against the endotoxin? We cannot. That is correct. So they are released upon cell lysis or by living cells, by blips detaching from the outer surface membrane, as you can see here. Like they just detach from it, or when it's destroyed, they get released. While exotoxin, it's secreted. Yeah? So, versus exotoxin, which is actively secreted. The main effect is with the macrophage activation. So let me speak a little bit about this. So what happens exactly that your the bacteria releases some of these cell wall structure, which are the lipopolysaccharide. They go to the macrophage. This is a macrophage. And this little structure, this endotoxin, they also call it BAMPs, okay? It's called BAMPs. This BAMPs will attach into the macrophages, okay? They attach to the macrophages on something called the T-like receptor. So I'm going to write a toll-like receptor, but I call it's toll-like receptor, TLR, but I call it T for T-like receptor. Yeah, so it's a T-like receptor, which attaches what? The BAMP. So the T-like receptor attaches to the BAMP. It's also called the CD14. When that happens, the macrophage will get activated. It will start releasing complement, and it leads to tissue factor activation. We will see the importance of all of these procedures when they occur. So let's speak about this thing. The endotoxin, remember the toxic component, what was it? Lipid A. So the lipid A will lead to macrophage activation by binding to the toll-like receptor, the CD14 basically. Now I have a question. Which structure, what is the other name of the lipid A component that attached to the T-like receptor? Toll-like receptor. How do we call it? The structure that attaches to the TLRs. PAMPs. We call it PAMPs. P-A-M-B. This is important. You need to know about the relationship of PAMPs and toll-like receptor. So let's take a look. So the toll-like receptor is located on the macrophage. The BAMPs are particles which are basically from the microorganism. Yeah. So you can see here the BAMPs, which is basically pathogen-associated molecular pattern. Anyway, they come and attach to the what? Toll-like receptor, which can lead to release of many cytokines like interleukin 1 and TNF-alpha. Let me send you this. Okay. So, macrophage activation, toll-like receptor, it activates this, which is basically the CD14. It can lead to interleukin 1 and interleukin 6 activation, which can lead to fever. Also, the macrophage can release after its activation TNF-alpha, which can also lead to fever and hypotension. Nitric oxide also can be released, which can lead also to hypotension. Okay? Can somebody tell me how nitric oxide lead to hypotension? How can nitric oxide lead to hypotension? Vasodilatation, that is correct. By activation of which secondary messenger? Was it cyclic A and B or cyclic G and B? It was cyclic G and B. Yep, cyclic G and B, which activated the MLC phosphatase and led to smooth muscles relaxation. Yeah. So endotoxins, basically the lipid A component, also can lead to complement activation. So we have a creation of the C3A and C5A. Each of these are, if you remember, like H complement, when it was cut, it had like the one particle that we call it B and one particle that call it A. Yes? Mostly the B was well kept to use for another function, while the A went away, but it was used for creation of anaphylactic reaction. So the C3A can lead to histamine release, which can lead to hypotension and edema. Yeah? Because of the massive vasodilatation. The C5A can lead to neutrophil chemotaxis as well. So the neutrophil chemotaxis, it's occurring where? Is it inside of the vessel or inside of the interstitium? Where is the neutrophil chemotaxis happening? Is it inside of the vessel or inside of the interstitium? If you remember, guys, I told you that the cell, it transmigrate into the interstitium. After it's inside of the interstitium, the bacteria is located here. So the C5A will come and connect to it, and that will be a chemotactic agent for the neutrophil. Yeah? So basically, it will attach to it, the C5A, it will attach to it in the interstitium. Okay, the last thing, tissue factor activation. You are like, tissue factor? Never heard of this. Well, yeah, we did not do it yet, but you might... everybody in medical school at some point saw the coagulation factors. So let's take a look at them. Yep. So you remember this graph. Well, we had the intrinsic pathway, the extrinsic pathway. The extrinsic pathway is tissue factor, has something called tissue factor. This tissue factor can be released by the macrophages, and it can lead to what? Coagulation and formation of a thrombi and the creation of a state called DIC. I will explain what is DIC in a moment. But let's take an overview on this really quick. Guys, can you see factor 4 here? Where is factor 4? Can anybody see factor 4? You can see factor 12, 11, 10, 9, 6, 5, but there is no factor 4. Where is factor 4? For those who attended today's class, you can know easily that factor 4 is calcium, and it's used at multiple steps, okay? And if you get a question asking you, what is the smallest clotting factor? The answer is calcium, okay? So calcium is the smallest clotting factor. Okay, now comes the question, where is factor 3? I cannot see factor 3. So 12, 11, 10, 9, 6, 5, and 4. 4, we just spoke about it. It was calcium. I see that. But where is the 3? 3 is not here. Well, it is. We call it tissue factor. Okay, guys? So tissue factor is factor 3. Okay. So let's go back to microbiology. Yep. So as you can see, tissue factor activation leading to coagulation cascade. So when you have coagulation cascade, will you have a hypercoagulable state or hypocoagulable state? Hyper or hypo? A hypercoagulable state. So you will have a thrombosis or decreased thrombosis. You will have thrombosis. When you have a plenty of thrombosis, what will happen to the clotting factor and the platelet count? They will increase or decrease? No, they will go down because you consume them to make a thrombus. If you consume them to make a thrombus, the number of them, the clotting factor, will go down because you made a thrombus out of it, yeah? And the platelet will go down because you made a thrombus out of it. So it's true that you will have millions of thrombi all over your body. But now your blood, does it have any more platelet or a clotting factor? Yes or no? No. So when he does not have it, will you have hypocoagulable state or a hypercoagulable state? Exactly. So this is the idea of DIC, guys. In case of disseminated intravascular coagulation, actually, initially you have a hypercoagulable state. It's only in the beginning. But after formation of many thromboses all over the body, after some times, it becomes a hypocoagulable state. So the patient will start bleeding from every orifice he has. That's dangerous. It's actually fatal. Okay, so far so good. We are done with that page. Are endotoxin easy? Super easy, but let's speak about a couple of more things. So they mention here that the edema. What is the cause of the edema? The C3A. It's the anaphylaxis thing. Now, please try not to look at your book and try to just understand. The release of nitric oxide happens because of interaction with what? Macrophages. Well, the BAMPs, which is the pathogen associated basically factors attached to the what on the macrophage? What they attached exactly? Yep, the patrons attached to the toll-like receptor, exactly. Okay, what about DIC and death? The DIC was due to the release of which clotting factor? Which clotting factor was released? Excellent, clotting factor number 3, which has another name. What is it? What is tissue factor? Absolutely correct. And I want you to know that the tissue factor is one of the extrinsic pathway factors. Okay, so DIC, the endotoxins are located in the outer membrane, as you can see here. And they can lead to release of TNF-alpha, which led to fever and hypotension. Also, the O antigen, it's composed, what is composed of? Lipopolysaccharide. This lipopolysaccharide have the O antigen, the core polysaccharide, and the lipid A. The lipid A is the one that leads to the problem. It's extremely heat stable. So even if you cook that piece of food, it will stay alive. So that's problematic. Also, interleukin 1 and interleukin 6 are released, leading to fever. Neutrophil Chemotaxis, which is due to attraction utilizing the C5A. So I have a question. The neutrophil chemotaxis, is it happening in the interstitium or is it happening in the vessel? Interstitium, excellent. So, tissue factor activation lead to activation of the coagulation cascade, which precipitate to DIC basically. Okay, so DIC had, remember, hypercoagulable state, then a hypocoagulable state. So to be fair now, with this graph, it's a little bit too much. In the beginning, it's difficult, but by the time it becomes easier. I hope you guys were able to watch the videos I told you to watch today, because they are a must to do. So I want you to do something like this. First of all, you need to know that we have a gram-positive and a gram-negative bacteria. Let's speak about the staining mechanism really quick. So remember, how do we do the procedure of staining? First of all, we bring a petri dish that has the proper material for the growth of bacteria. Then what we do is that we bring a colony of these bacteria, put it inside, and we do inoculation of another bacteria inside. What is the next step? We wait for it to grow. Yes, we want it to grow. So it grows. After it grows, you have plenty of material to deal with. So what you do, you go to the next step. You go to the next step, which is basically putting them on a slide. You bring these guys and you put them on the slide. After you put them on the slide, you need to do what? You need to stain it. I want you to know that the first stain that we actually utilize, it's purple, violet blue. Just a second. I cannot find the tool I normally use. Well, anyway, just know that it will be colored purple. Let's take a look here. Okay, purple enough. It will be colored purple, the whole thing. After this, you remember maybe in the gram-positive and the gram-negative bacteria, they had a layer called peptidoglycan. Can you tell me, please, which bacteria has a thicker peptidoglycan? Was it a gram-positive or a gram-negative? Gram-positive had much thicker peptidoglycan. You are absolutely correct. So that will be able to suck. First of all, let's take a look at it to see what this is peptidoglycan. Remember this layer? Look, here you have one layer of peptidoglycan. This is a gram-negative. Gram-positive has plenty of peptidoglycan. So when I bring this color and I put this dye in here, it will come and stuck into the peptidoglycan. So it will look more blue, yeah? Good. So it will look more blue. And next thing, like when you add it to the culture, basically, when you add it to the culture, the color, it will make the whole thing blue. Okay, so then you wash it off. If it was a gram-positive, will it wash off or no? If it was a gram-positive, it will bind to the peptidoglycan and it will not wash off. Yes, it will not wash off. Why? Because it's peptidoglycan. But if it was a gram-negative, the peptidoglycan layer is super thin. So will it wash off? Yes, so take a look. We wash it off. Done. It's gone. So the next step is to do what? The next step is actually to put a different color. Which color do we put? Red color. Okay? So you put the red color. Yeah? After this bacteria, well, obviously it will become red. So this is gram-negative bacteria. Okay? So I hope it makes sense. So the next thing we will speak about after discussing gram-positive and gram-negative is to discuss basically different types of them. So the first thing we discussed regarding gram-positive and gram-negative was the structure. Now we will discuss it according to the shape. Now forget about all of the gram-negatives you know. We'll speak about the gram-positive. So we have the Cocci. Cocci means a sphere. Bacilli means a rod, yeah? And the branching filament are something else. So Cocci, these are the most important group. Why? Because it's big, it's really big. So that's why I want to finish with it as fast as possible. We have, first of all, according to the catalase activity, you today guys did Staphylococcus Aureus. Did you see a cat in that video, Staphylococcus aureus? Did you see any cats? Here is the cat. Remember about the cat? This is the cat in the video. So the cat represents catalase positive. Catalase positives are really dangerous in which disease, guys? CGD, absolutely correct. Chronic granulomatous disease. Yep. So let's take a look. You can see that the in Staphylococcus aureus, it is catalase positive. Now the next question. Staphylococcus, what does the word staphylo mean? What does staphylo mean? It means a cluster. So I want you to actually, like when they saw it the first time, they thought it looks like grapes basically. What the? No, fruits. The grapes, I mean, as in fruits. Yeah. And yeah, so they thought it looks like grapes, and according to that, they named it Staphylococcus aureus. So coccus is a sphere. What about aureus? What does the word aurum mean? It's gold, it's gold, it's gold. So take a look here. Is that gold enough for you? It is gold enough for me. So do not be tricked. It's a gram-positive bacteria. So what will be the color of the bacteria under microscopy with the gram stain? Purple, exactly. It's a Staph Aureus if you visualize it with electron microscopy or something like that. But in reality, when you do the gram stain, it's purple. Why also it's important to know about the Staphylococcus aureus that it is has the color of gold. Take a look. On the skin, it can lead to crusts. See this lesion? It is yellow. So it's caused by which bacteria? Which bacteria has yellowish discoloration, can lead to this crusts? Staphylococcus aureus, yes. The yellow crust are Staphylococcus aureus. Good. So the next thing I want to speak about is, okay, so that's Staphylococcus. Is that everything? No. Guys, we'll speak about it alone a lot, but now I'm just giving general ideas. So the next thing is coagulase. Guys, I don't want you to worry about this too much. There is only one bacteria in the whole USMLE that you need to know about that is coagulase positive. And that bacteria is, do you know it? No, it's actually Staph Aureus. That's it. Look at Moses. Moses was able to coagulate the Red Sea. Yeah? So when Moses coagulated the Red Sea, he was like, he coagulated it and he split it into two. Yeah, so Moses is going through the coagulated sea. So that's coagulase positive. It's the only coagulase positive organism you need to know in the whole book. Okay, well, that's good. And now when we go back here, you can see Staphylococcus aureus are coagulase positive. Well, what about the other staphylococci, like Staph sabrophyticus and Staph epidermitis? Were they coagulase positive or not? Yep, they had the jelly. Exactly, absolutely correct. So, not this one. Just a second. Yep, they had the jelly. Remember about the jelly? The jelly was not coagulated yet, so it was coagulase negative. What about the catalase activity in this picture? Is there a cat? Here is the cat. So, it is catalase positive. Done. So if they ask you, how can you differentiate, guys, between Staphylococcus aureus and Staph sabrophyticus and epidermitis? Which test you will do to differentiate between the two? Done. Coagulase. If the organism was coagulase positive, this is Staphylococcus aureus. If it was negative, it's one of these guys. Okay, good. So let's go back here. Now, there is something called novobiosine. Novobiosine, again, one biochemical test that you can do to differentiate between two microorganisms. So we have Staph epidermidis and Staph sabrophyticus. Staph epidermidis is mostly like it can affect the heart. It's normally located on your skin. So yeah, that's important. Staph sabrophyticus, it can lead to UTIs in sexually active ladies, exactly, in sexually active ladies. And guys, I have a student today who did his test and he got a question about this. They showed him a picture of the Staph sabrophyticus. Before I Google it, is it a cluster or chain? Staphylococcus sabrophyticus. Excellent, it's a cluster. It's a staphylo. They look like clusters. So they showed him exactly this image, and he was able to see the clusters, and they were gram positive. They were bearable. When he saw that, the next thing, they tell him that she is a sexually active lady. And they ask him what's up. Well, he had to say it's a Staph sabrophyticus. That's it. Okay, good. There is novobiosine sensitivity, if it is sensitive or not sensitive. If we speak about novobiosine, exactly the belly button, the navel. So if you take a look at about this guy, it's exposed. So he's novobiosine sensitive. While in the lady, her navel is covered. So she is novobiosine resistant. Her navel is resistant, while the guy navel is sensitive. Okay, so that's a way to differentiate between the two. Look at this lady having UTI. Yeah. Okay. So the next thing we are going to speak about, since we finished with all of the clusters, now we are going to speak about the strep. A strep is basically a chain. Okay. A chain can be made from how many balls, guys? How many balls you need to make a chain? How many of these circles? At least two. At least two. So if it is two, do we consider it strepto? If it's only two? Yes, we do. We consider it strepto even if it was only two. This is important. When we speak about the streptococci, you don't have to know all of these. Today you have just to prepare the Staphylococcus aureus. You have to cover like some other microorganism, but not everything. So I understand if you don't know all of them. So I want you to know one thing. So we have a streptococci. Streptococci can be wide range. They can be so many different things. So because of that, they decided to do something about it. What they decided to do is to do a test with hemolysis, okay? So this test with hemolysis include the following. They bring a culture, they put it like here, like this, and then they inoculate some bacteria inside. And they start checking if there was formation of hemolysis around it. And if there was formation of a complete hemolysis around it, what do we call it? Let me repeat what I just said. I'm going to, yes, this is the colony with bacteria. And obviously, oh, this is much better. Just a second. Oh, why I'm not using this? Okay, so this is the culture and it's full with the blood, correct? Blood is not white, guys. Blood is red. It's full with the blood. And then we inoculate some bacteria inside of it. Just a little bit of bacteria, as you can see. After inoculating this bacteria, you start checking. Well, was there clearance around it? So you take a look at it. If there was, around the colony, you had why the blood has gone? Because it was destroyed by some enzymes released by the bacteria. Okay? So when you see something like that, we call it beta hemolytic. Okay? They were like, okay, fine, well, not bad. What about if there was zero hemolysis, no hemolysis at all? There was no hemolysis. How do we call it? No hemolysis at all. Gamma, exactly, it's gamma. Okay, if it was partial hemolysis with the greenish hues into it, like something like this. Alpha, yep, it's alpha. So now let's just take a quick look about them. Oh, nice picture. So beta hemolytic. Yes, you can see here the beta hemolytic, you can see clearly there is a space. Here there is a minor space and it has a greenish hue over the whole thing. Here it's completely the same. Yeah? Guys, one quick question. This organism has no hemolysis, so how do we call that? Gamma. Excellent. Yep. Again, alpha hemolysis, greenish hue. Beta hemolysis, actual hemolysis. Gamma hemolysis, zero hemolysis. Yeah? Yep. Okay. So after we spoke about this, now we can go a little bit deeper without feeling guilty. So, starting, of course, from the beta hemolytic, which is complete hemolysis with the clear areas. The next test that you can do is something called Biscitarism Sensitivity and BUR status. These are represented on a sketchy with the what? What they put in sketchy to represent it. Do you remember? What do they put in a sketchy to represent it? Biscitarism positive, exactly, the horned, yeah? So you can see the Biscitarism sensitive, the dog has no mask, so he's sensitive, yeah? While if you take a look at the Galacticus, he has a mask, so that, the dog has a mask, not the shell. The dog has a mask, so that make him resistant. Again, guys, these are just biochemical tests. This is the only thing you have to know about this. So, if you take a look back to here, the positive, according to the sensitivity, the dog was positive in case of the Strep Biogenes. Since it is a strep, it is chains. And since it's a positive with Biscitarism, the dog there had no helmet. Well, in case of the Strep Galacticus, he had a helmet, so he's resistant, okay? So he has negative sensitivity. Good. So the next thing I want you to know about is something called partial hemolysis. So partial hemolysis will have this greenish hue. And we decide about it like according to the optician sensitivity and bile solubility. When we speak about this video, I don't know if you did it today or not, but it had one thing that was really important actually in the video. So they spoke about the fact of the boots and the shin, exactly. So this guy's shin, the viridans, this is the viridans in this area, and this is the Strep Pneumonia. So which of them has a mask, like covering his whole face? It was the viridans, yes. So what about the other guy? Well, he has exposed chin. Yep. So according to this, some guy has a shin exposed, some guy has a chin closed. So the epto-shin sensitivity for the Strep pneumo, his shin is sensitive, while this guy, his shin is resistant. Resistant shin, sensitive shin. And with the bile solubility, take a look at this guy. He has a freaking boots. So that means he's bile resistant, he's bile insoluble. Well, this horse had no boots, making it bile soluble. Yeah? So you can see here, according to the bile solubility, Strep pneumo, bile soluble. Viridans, bile resistant or insoluble. Okay, good. Now, these days, they don't use the word viridans anymore because everybody know it basically. So they call it Strep mutans or mites. I want you to know also that the Strep pneumo is an encapsulated organism, and it was the most common bacteria to infect whom? Who was at the highest risk of infection because of it? Yep, people who don't have spleen. Yep, exactly. It's also community acquired, I agree, but the asplenic patient are the highest risk. Okay? So the next thing here we have is this area, gamma hemolysis, which means no hemolysis. Yeah? Gamma hemolytic, it means it does not have any hemolysis. But they grow in 6.5 NaCl. So I have a question. If they tell you the organism grows in a sorry, I should tell you this. 6.5 NaCl, is it hyperosmolar or hypoosmolar? Somebody wrote hyperosmolar. What is the normal percentage of NaCl solution that we give for the patient that represents the normal basically concentration inside of our plasma? 0.9%, correct, it's 0.9%. So not 90%, 0.9%, so it's like 0.9%. So if we say 6.5, is this high or low compared to 0.9%? Ridiculously high. So they can tell you the organism grows in a hyperosmolar media. This is exactly the same as telling you it grows at 6.5. The exact same. The organism grows at a hyperosmolar media. Okay? Good. So let's take a look. As you can see here, we have the following organism. The first one, we have the Enterococcus, Physium, and Fecalis. These are super dangerous, and I want you to know one thing about them. They happen mostly after urogenital tract manipulation. Okay, so as you can see, this guy is holding the sign resist the 6.5 NaCl. Yeah, so basically they are doing a protest, and you can see here is the guy. He's quite resistant even to vancomycin. Oh, and this is important. Can somebody tell me how can this organism become vancomycin resistant? By creating what, basically? How can she become resistant to antibiotics? It becomes resistant to antibiotic utilizing transposition. Reutilizing transposition, in which it moves one structure from the DNA to the plasmid, okay? And after that, it can go to other organism using transformation to spread the info. Well, a transformation, it's, if you remember, we spoke about it yesterday, and it was like taking up dead DNA. So if the dead DNA does have the immunity against the vancomycin, it's true, you can get immunity. But what I'm saying, how it can happen de novo, which means like from zero, yeah? So it can happen due to creation of the plasmid. What creates a plasmid? Transposition, okay? Okay, good. So the next thing, the next thing is the bovis. The bovis is important, strep bovis. Strep bovis, write a note next to it, associated with colon cancer. So they can tell you about a story about someone with infective endocarditis, and then they mention a strep bovis. Stop thinking it's colon cancer. They tell you what to do next, what you should do next, guys. What you should do next if the patient has endocarditis due to strep bovis. The next step of management. Check for colon cancer. How to do that? With a colonoscopy. Excellent. Yes, absolutely correct. Good. So, yep, all good, all good, all good. So, all of this area is clear, all of this area is clear. Congratulations, we finished the cocci. Let's take a look at the bacilli. Well, if we speak about the bacilli, bacilli means road, yeah? Road means road. So we have aerobic and non-aerobic. Aerobic ones are Listeria, which is important in a pregnant lady. We have the bacillus, like Bacillus anthrax, for example. Well, anthrax love the lung, so it means it's aerobic. Corynebacterium, which can lead to the pseudomembrane inside of the throat. In Sketchy, how do they represent aerobic versus anaerobic bacteria? So let me show you. So during the Sketchy, you will be focused on the mask, exactly. The mask and the bump, the air bump. So if you take a look at, yes, this guy. Can you see this air bump with his hand, in his hand? This represents the organism being aerobic, okay? And if you take a look at this guy, his mask represents the organism to be anaerobic, okay? Aerobic and anaerobic. So if we speak about Listeria, Bacillus, and Corynebacterium, all of them are aerobic. If you speak about the anaerobic bacteria, they include the Clostridia, Cutibacterium, formerly called Proabiobacterium. Guys, this Cutibacterium is important in which disease? Which disease can Cutibacterium lead to? Something all of us has suffered from. Not paralysis, come on. Something all of us have suffered from. Acne, okay? They can lead to acne. This thing. So the Cutibacterium, really quick. Why does acne happen? You need to know why acne happens. So in acne, basically the skin clothes. The pores of your sweaty gland. No. Cutibacterium. So, okay, got you. Yes, if it was the case, that will be correct. For the Cutibacterium, it can lead to acne. Basically, this bacteria will go inside of the pores, and your pores will be closed. And anytime you have occlusion, what will happen behind it? Inflammation. So that lead to acne. Yeah? Okay. So the last thing, we have branching filaments. We have aerobic and non-aerobic. There is something important about these guys. These guys, back in the time, they thought that they were not even bacteria. So let me show you why. Actinomyces. They used, yeah, exactly. They thought that they were fungi, but they discovered they are wrong. I will tell you why they discovered they are wrong. So if you take a look at it, it looks like fungi, not like a bacteria, you know? So it does actually look like a fungi. If you look, for example, at, I don't know, mucormycosis, yeah? You know, this black death fungi. Mucormycosis. But I wanted to Google mucormycosis and histo. I want a culture in vitro, not this, basically. Well, basically, oh yeah. See, it has something like filaments, yeah? It has like these filaments. And if you look at actinomycetes, they do have this as well. So it was used to be thought as a fungi. It has this mycelium, we call it actually, which is like this fungi structure, mycelium. But they discovered they were wrong. Why? Because when they tried antifungal drug on this guy, they did not work. When they tried antibiotic, it worked. So it means it's a bacteria, not a fungi. So they have a branching filament. If it's aerobic, nocardia, mostly affect the lung. It's weakly acid fast. Acid fast is rare. What other organism is acid fast? Do you remember, guys? TB, yes. While actinomycetes are not acid fast and they are anaerobic, they can lead to jaw infection. So this is everything in the gram-positive laboratory algorithm. It's a lot, I know, but a step at a time, you will be able to cover all of them. So, to be fair, sketch a make this a piece of cake. So, gram-positive cocci antibiotic test. For Staphylococci, we have the novobiocin. So we have novobiocin, saprophyticus is resistant, and epidermitis is sensitive. Remember the lady umbilicus? The saprophyticus, she had her umbilicus hide, the lady in the video, in the sketchy. So it hide, that's resistant. The guy, it was exposed, so that's sensitive. The last thing before the break is the streptococci. We have Optochin, sensitive and resistance. So remember the Viridans, he had a mask on. So his chin was resistant. Viridans is resistance. While the Strep Pneumonia, his chin was exposed. So it was sensitive. The next thing is Bacilli. Group B strep are resistant. Why? They had a helmet on, a Galacticus, if you remember. While the group A, which is Biogenes, is sensitive because he did not have a helmet on. Okay? They have mnemonics here. These, personally, I think they are totally useless. You just guys have to do sketchy and you will get all of these. Okay, let's take a little break now. 10 minutes break and come back and do more of these bacteria. So see you guys after the break. Hello everybody, welcome back. So, the next thing we are speaking about is alpha hemolytic bacteria. And the hemolysis in these bacteria, you must know that it will be partial. When we say partial, plus one more characteristic, which color it will have? Absolutely correct, it will be green. Somebody just joined. So, alpha hemolytic bacteria are gram-positive cocci. They have partial oxidation of the hemoglobin, which leads to creation of a greenish or brownish color, without clearing around a growth on the agar, which means partial hemolysis and only change in the coloration. The bacteria that does this on sketchy, you can see them on the same video, which is this one. And where is the alpha representation? The alpha night, yeah? So both of these organisms are alpha hemolytic, yes? So, Strep Pneumonia, catalase negative, and Optochin sensitive. Remember, his chin did not have a mask on it, so it was sensitive. Viridans, catalase negative, and Optochin resistant. Yep. The beta hemolytic bacteria, on the other hand, are again gram-positive cocci with complete lysis of the RBCs. So they will have a clear area surrounding the colonies of bacterial growth, okay, on the blood agar. They include the following. Staph Aureus, remember, it's a catalase and coagulase positive. The cat, and the mosas coagulating the C, the red C. Streptococcus Biogenes, it's a group A strep. It's a catalase negative and Bacilli sensitive. Remember the honed the dog basically with his face without a helmet, so it's sensitive. While in case of Strep galacticus, the dog had a helmet, so his head was resistant to the injury. So Staphylococcus aureus is a gram-positive, beta-hemolytic, catalase positive, coagulase positive cocci in clusters. All of these characteristics we have already discussed. We understand what a gram-positive mean. We understand what beta-hemolytic mean. We understand what catalase and coagulase positive means. So the next thing I want you to know, it has something called a protein A. What is a protein A? Protein A is basically a virulence factor that binds the Fc portion of an antibody. So if we say that this is the Staphylococcus aureus, just one cell, it has on it something called protein A. This protein A will basically be able to bind the what? The antibodies. But where? At their Fc portion, which is the lower portion, yeah? And they will bind to the antibody, and after they bind to the antibody, they will prevent them from functioning, which can lead eventually to inhibition of the complement activation, and also it will lead to inhibition of the phagocytosis. I hope it makes sense so far. Normally it's on the Fab, right? What is on the Fab? Can you please elaborate on that? So they bind to the Fc region, okay? So if you're asking where does the IgG binds to? Well, the IgG binds the antigen using its Fab. That's absolutely correct. You are right. So you must know one thing. It commonly colonizes the nares, the ears, the axilla, and the groins. To be fair with you, they always ask about the nares. You must know that inside of your nose you have normally Staphylococcus aureus, and it can lead to colonization all over your body, creating recurrent abscesses. And the only fair treatment will be to decolonize the nares. Let's take a look at the sketchy picture for a moment. So we spoke about first of all, the protein A. So you can see how Moses, this is Moses, and he is holding basically his staff, and this staff is having this A on it, which is the protein A, which binds, see the antibody? It's the Fc portion of the antibody, not the Fab. This is the Fab portion of the antibody, and this is the Fc portion of the antibody. So he's binding to the Fc portion. Also, I hope you can see the nose here. And historical fact, this guy, which is the Sphinx in Egypt, does not have a nose. Does anybody know why he does not have a nose? That's interesting factoid. Nobody knows why the Sphinx in Egypt right now does not have a nose. Well, basically, Sphinx. Basically, let me tell you. So the Sphinx in Egypt, why it does not have a nose? Because Napoleon Bonaparte, in the year 1802, when he was in Egypt, he decided to destroy the Sphinx to show his power to the Egyptians, to show that, okay, I'm so strong, I can do whatever I want. So he tried to do that, but what happened was that he wanted to destroy the Sphinx. He kept shooting at him with all of the cannons, but the only thing that he was successful with is what? Destroying the nose of the Sphinx, okay? So this is the nose, the distracted nose. So that helps you to remember that it colonizes the nose, okay? The next thing, to know is the causes. First of all, it can cause inflammatory disease. So it can lead to inflammatory disease such as skin infection, organ abscesses, and pneumonia, often after influenza virus infection. So this is serious, guys. This we call bacterial on viral infection. So basically, the virus, when it affects you, it leads to some destruction, but it will be cleared out. But if you get bacterial on viral, that's super serious. That can kill the patient, okay? They also can lead to endocarditis. Do you remember in which category of patient they can get endocarditis from Staphylococcus aureus? Which category of the patient can get it? IV drug users. And which valve will be mostly affected? The tricuspid valve. Excellent, excellent. The tricuspid valve, because it's the first valve to be hit by the microorganism when the blood comes back, basically, yeah? So you can see here skin infection, organ abscesses, and pneumonia, often after influenza. Okay? So we also have endocarditis, and we have septic arthritis and osteomyelitis. Something to know about septic arthritis. Septic arthritis, the amount of white blood cells inside of the joint on the aspiration of the joint. Remember, in septic arthritis, what do you do first? The first step of management of septic arthritis. Is it antibiotic, or is it putting a huge needle that is really painful inside of the joint? Or is it taking an X-ray of the joint? What do you think? What sounds more right? Exactly, it's the synthesis, putting a huge needle inside of the joint. Yep. So why? Because if you don't do that, the whole joint will be destroyed, the whole cartilages will be destroyed, and this whole thing will need replacement. So the first thing to do is to do this thing. Yep, you bring a syringe and you suck all of the pus from the joint. In case of septic arthritis, I want you to know that the amount of white blood cells inside will be ridiculously high. You are speaking about like more than 50,000, more than 40,000, really huge number, okay? So next thing, osteomyelitis. Now a logical question, what is osteomyelitis? Well, osteomyelitis is an inflammation of the bone. You are like, well, what about septic arthritis? That's an inflammation of the joint. So osteomyelitis, it's an inflammation of the bone, but to be more fair with you, it's an inflammation of the bone plus the bone marrow. So when the bone marrow is inflamed, we call it osteomyelitis, yeah? So you can appreciate, how do you know that septic arthritis, not regular arthritis? Well, in case of septic arthritis, it's ridiculously painful. We'll speak about it in MSK, but you can diagnose it clinically, basically. The patient will come to you, will be telling you that, doctor, it's ridiculously painful. Like it's so tender, they cannot put their weight on it at all, and it happens suddenly, not over time. For example, in rheumatoid arthritis, yes, it will be painful, but it will not be debilitating in a way that it will prevent them from moving, okay? But this one is so horrible that there is no way they can move. And if you touch it with your finger, the patient will start screaming. That's how painful it is, okay? So that's actually a step 2 question. Really interesting. Good question. So toxin-mediated disease. So toxic shock syndrome, type 1. If you remember, in case of toxic shock syndrome, I told you that the way that the super antigen work and the Staphylococcus aureus toxin work, it leads to hyperactivation of the T cells. How it does that? Well, normally antigen processing goes like this. We have the antigen presenting cells, which present an antigen to the T cells, and that leads to a response. But in some cases, we have something called super toxins, okay? How do they work? They lead to direct activation of the T cell receptor. Direct activation of the T cell receptor lead to a non-specific proliferation, and that basically the idea of super antigen. It's basically creating of a huge response that is highly inappropriate, okay? So that can lead to scald skin syndrome. Basically, it's the exfoliative toxin that leads to that. And I want you to know one thing about this one. These patients have something called Nikolsky positive sign. Let me show it to you. So this patient, when you bring your hand and you try to basically slide it over their skin, what will happen is that their skin will slough off. Yeah? That's a highly important fact to appreciate. Their skin sloughs off when you try to do that. Good. So the next one, rapid onset food poisoning. Maybe you remember you ate at some place something with mayonnaise, for example, and after you ate it, you felt bad. And then you started vomiting with horrible diarrhea, and all of these symptoms lasted for less than a day, and then they went away. So now comes the question, which of the following bacteria caused this? 1. Staphylococcus aureus. 2. Bacillus cereus. 3. Salmonella. 4. Cholera. As you can see, all of these can lead to diarrhea, yeah? And some of them can lead to vomiting as well. The only way was to differentiate between the two was by knowing the timeline is important. That helps you to say, okay, it's not salmonella, it's not cholera. But how can you differentiate between Bacillus cereus and Staph Aureus? They have the similar amount of time. Exactly, it's what they ate. So if we speak about the Staph Aureus, it can happen from what? Some meat, mayonnaise, custard, stuff like this. All of the delicious stuff that you are kept on the sun. So let's take a look on sketch. So on sketch, what they write, you can see here, the lady is vomiting, yeah? And it's a rapid onset food poisoning. Notice here, it's heat stable, which means it cannot be destroyed by cooking the food for a really short period of time. You need to cook it in a really hot way for a long period of time. So even if you cook it, you will still have the toxin in there. It's meat and mayo, so mayonnaise and meat. And please add custard. Custard as well can lead to it. Okay? So, the food is important. What about Bacillus cereus? Does anybody know what causes it? Bacillus cereus. Which food? Which food can lead to Bacillus cereus? Well, vegan food, to be more exact, rice. Rice, okay? Reheated rice, absolutely correct. Good. So MRSA is our friend, so let's keep her for later. So let's just finish up with these and then speak a little bit about MRSA. So the toxic shock syndrome is a toxin, basically, is a super antigen that binds to the MHC and the T cell receptor. You are like, how would it do that? Take a look here. It's binding to both the MHC and the T cell receptor. So 2 in 1, yes? It's activating directly. You don't even need an antigen peptide anymore. You can activate this directly. It leads to non-specific proliferation, and that's the problem. It results in a polyclonal T cell activation and cytokine release. Why they write the word polyclonal? If they wrote monoclonal T cell activation, which disease is this? Which disease has a monoclonal T cell activation? Monoclonal. Leukemia. Leukemia. Monoclonal means all cells came from one cell, which is due to genetic mutation of that one cell, which is highly specific for cancer cells, while polyclonal is just a form of hyperplasia, which is benign. Okay. So they write resulting in polyclonal T cell activation and cytokine release. So now we speak about MRSA. Let's finish up with MRSA. MRSA is an important cause of nosocomial. What does the word nosocomial mean, guys? Is it coming from the nose? What does nosocomial mean? Yep, it happens in the hospital. Absolutely correct. It's from the hospital. So nosocomial and community acquired infection. Back in the time, it was only nosocomial. Now it's also community acquired, okay? So the resistance happens due to altered penicillin binding protein, which is conferred by MACA gene. Basically, there is one gene. When this gene is defective, the penicillin binding protein will be altered. So when the penicillin binding proteins is altered, can the penicillin bind to it anymore? Yes or no? They cannot. So in case of MRSA, you cannot have binding of penicillin anymore. If you cannot have binding of penicillin anymore, you don't have function of penicillin. So the patient becomes basically resistant, sorry, not the patient, the bacteria becomes resistant to the penicillin. Some strains also can release BVL, which is Banton Valentine leukocidin. Leuco means white blood cells, basically. Cidin, if it's like cidal. What does cidal means, guys? What does cidal mean? We say bactericidal. We say leucocidal. What does cidal mean? Killer, exactly, killer. So it's leucocidal. So some bacteria releases this leucocide, which kills leukocytes and causes tissue necrosis. Yeah? So it's a way of the immunity of the bacteria against our immune system. Wow, that was a lot of immunity words in one sentence. So staphylococcal toxic shock syndrome will have fever, vomiting, diarrhea, rash, desquamation, and shock. To be fair, if you notice here, all of the symptoms are systemic, not localized by systemic. Also, they can have end organ failure. So, toxic shock syndrome results in an increased AST and ALT, which are enzymes of the what? AST, ALT. Yes, they are for the liver. So, and increased bilirubin because of the destruction of the RBCs. Write a note about that. It's associated with the use of, oh, this is super important, vaginal tamponade and nasal backing. So what is the idea of these? Guys, these are serious stuff. Some ladies use this vaginal tampons that they put it inside of the vagina. Not the outside one, but the inside one. Okay? So they put it inside during their menstrual cycle, and I don't know how, but they forget about it. So they forget about it for 2-3 days, okay? They keep it inside and they totally forget about it. They don't touch it for 2-3 days. Who will love that? Who will love the fact of that there is a stasis in the area? Bacteria, especially which one? You give it blood full with the nutrient. You know, blood is full with a nutrient. So, blood full with nutrient, warm place, and tampon that is blocking the area, which leading to stasis. Staph Aureus will come to you and tell you, thank you so much, sir. I don't believe you are doing all of that for me. So, yeah, basically, this can lead to, I will show you just a second. So, this nasal backing and vaginal tamponade, both of them can lead to toxic shock syndrome. So let's take a look at toxic shock syndrome. Oh, first of all, this is the nasal backing. Okay? Sometimes it's super important, especially after surgery. We do it for the patient. But the idea that you need to remove it every day, not leave it there for 3-4 days, that's just a bad idea. You know? So it can lead to toxic shock syndrome. Okay? actually you can just take a quick look about how big this structure is, and yep, you just a quick look, just take a look how, see, this is the nasal backing. If you don't remove it early, oh yeah, so this is normal, it's big, I know. Yep, having nightmares. So if it stay inside for a really long time, it can lead to colonization with the Staph Aureus, which can lead to toxic shock syndrome. Okay, so compare it to Strep Biogenes, which also can lead to toxic shock syndrome. Toxic shock-like syndrome, which is caused by Strep Biogenes, is associated with painful skin infection. Okay, painful skin infection. Staph Aureus food poisoning due to ingestion of a preformed toxin, short period of incubation, 2 to 6 hours, followed by a non-bloody diarrhea and emesis. They start vomiting, watery diarrhea. Enterotoxin is heat stable, which means you cannot destroy it by cooking. And the Staph Aureus makes coagulase and toxins. They form fibrin clot around itself, which can lead to abscess. So now we'll speak about why the coagulase positive thing, which is, what is the only bacteria in our body that is coagulase positive? The only bacteria in the first, in USMLE, yeah, the Staph Aureus. That's it. So, and that gives it a really important characteristic, the ability to make abscesses, yeah? Why? It creates a fibrin clot around it, and that fibrin clot basically protects it from destruction, and inside of it you will have the what? The Staph Aureus living happily forever after. And that's a Staphylococcus Aureus abscess. Notice please that in this abscess, what is the color? What is the color of the pus? It's yellow, okay? So, and that's it for this one. So that's everything you need to know about Staphylococcus aureus. Oh, one last thing. Guys, in case of endocarditis from Staphylococcus aureus, this is a difficult question. Does it affect damaged valve or normal valve? Normal valve, exactly. It's normal valve. But very dense, does it affect damaged valve or normal valve? Only damaged valve. Excellent, only damaged valve. This is important. One more thing. In case of Staphylococcus aureus, the vegetation, are they small or huge? In case of Staphylococcus aureus, they will be big, okay? They will be huge. In case of very dense, they will be small. So let's take a look at the vegetation. Okay, you can see the vegetation here are quite big, okay? So that will be aureus, yeah? Staphylococcus aureus. If they were small, it will be what? If they were small, it would be very dense. Yep, it will be very dense. Okay, good. So let's go back here. Let's speak about Staphylococcus epidermitis. So don't look anyway, just look in the air. Tell me please, Staphylococcus epidermitis, is it coagulase positive or negative? Negative, done. Anything that is not Staph Aureus is coagulase negative. Okay, just a quick trick. All Staphylococci, all of them, are catalase positive, okay? So, it's also urease positive, which means it can convert ammonia into urea, okay? And they can lead to formation of cocci in clusters, okay? So it's novobiocin sensitive, does not ferment mannitol versus Staph Aureus. Staph Aureus, mannitol, what is that? Well, mannitol is a test that you can do in the mannitol salt agar. Yep. And you can do Staph Aureus and it will be yellow, yellow, yellow. Okay? So a yellow color is a positive test. Good? So this is Staph Aureus. It's yellow. So that's a positive test. Let me send this for you. Okay. Well, how they represent this on Sketchy? Let's take a look. Well, on Sketchy, they give you this yellow, well, this man, so it's mannitol, it ferment mannitol, which gives, see his yellow agar, yellow shirt, basically, yellow clothes. So this is the mannitol. Well, he's a tall man. Okay. We spoke about the exfoliative toxin, scaled skin toxin. We spoke about MRSA. The treatment is nafcillin, but in case of MRSA, you cannot use penicillin, obviously, because there is alteration of the BBB site. So you have to use a vancomycin. Keep in mind that it can lead to aseptic arthritis. It's associated with IV drug users and can lead to acute bacterial endocarditis. It can lead to abscesses, especially because it's coagulase positive, and it can lead to post-viral bacterial pneumonia. Yep. So for Staph Epidermitis, it's a normal skin flora. It contaminates blood cultures. This is super common because basically it's everywhere. It can be contaminating the blood culture. So I have a question. If someone you took a culture from a patient and you find that he has Staph Epidermitis, what is your next step? What you should do next? The next thing to do, I will give you options. 1, give antibiotic. 2, take the culture again. 3, do chest x-ray. You have to do it again because there is really high chance that it is contaminated, okay? So it can infect the prosthetic devices such as hip implant, heart valves, and IV catheters by producing adherent biofilament. Guys, biofilament, are they proteins, sugars, or what are they? What are biofilaments? No, I posted a question about it in the group. A lot of people answered it incorrectly. So if you remember, guys, I posted a question here yesterday because I knew this is a difficult one. Yep, the slime is the biofilament basically, and it's a sugar. Okay, it's a sugar. Okay. So the biofilm are made out of sugar, which is really sticky. Think about it as a honey, for example. It's made out of sugar and it's really sticky, which help it to stick to the heart valves, for example. Yeah? Okay, good. So the next thing I'm going to speak about is Staph sabrophyticus, the lady. She's a gram-positive, catalase-positive, coagulase negative, urease positive cocci clusters. I hope you can imagine all of this stuff in the pictures in your brain right now. So it's novobiocin resistant. Remember, her navel was covered. It's a normal flora of female genital tract and perineum. Second most common cause of uncomplicated UTI in young female. So if you get a sexually active lady with a UTI and they ask you, this is most likely due to what your answer will be? Excellent. It's E. coli. The second most common cause is Staph sabrophyticus. They love to play with you with that question. So, except if they told you it was a gram-positive or they told you some like characteristic of a gram-positive organism, in that case, you choose this. Okay, so one more before the break. Let me tell you about Strep Pneumonia. It's a gram-positive alpha hemolytic lacent-shaped diplococci. A lot of students, when they hear the word lacent shape, they don't get it. Well, basically it means that it looks like this. Okay? This is lacent shape. So what I want you to know, first of all, how it looks like. It looks something like this. Can you see the lacent shape diplococci? Yep, diplococci. Guys, since it's 2 at 1, 2 at 1, 2 at 1, is it a cluster or is it a chain? It's a chain. Good. Does it have a capsule? Okay, good. So Streptococcus pneumonia is a gram-positive alpha hemolytic lacent-shaped diplococci. It's an encapsulated organism and has an IgA protease. This IgA protease help it to affect what? What is the importance of an IgA protease? It destroy IgA and lead to affection of mucosal surfaces. Yeah, including the respiratory tract. Yep. It's optogen sensitive and bile soluble. Remember, the guy had no boots, so he's not bile insoluble, he's bile soluble. He also has an uncovered chin, making him optogen sensitive. Remember also in the sketch sheet they mentioned the MOPS. So it can lead to meningitis, otitis media in children, pneumonia, and sinusitis. Pneumococcus is associated with a rusty sputum and patient with hyposplenia or acyplenia. No virulence without capsule. I have a question with you. If they give you a splenic patient and they put for you the following answers: H. influenza, Streptococcus pneumonia, and Staphylococcus Aureus and E. coli, and they ask you what is the most common cause? Strep pneumonia. The most common cause of meningitis in children and strep pneumonia in adults. Strep pneumonia is the most common in children and in pneumonia in adults. Well, the most common cause of pneumonia in children, this is an inaccurate question. Why? Because you will discover that in the near future, when we'll speak about the systemic microbiology, I will be telling you that speaking about meningitis, for example, it has a long story. So you can see that children, well, what type of children are you speaking about? The newborn or actual children? If it was actual children, the most common cause of meningitis is not Neisseria meningitis. It's Strep pneumonia still, okay? So that's important. The most common cause of meningitis in children is Strep pneumonia, not Neisseria meningitis. Neisseria meningitis is the second most common cause. So to move back to the, where is the page? Seriously? The page went away. Okay, you have a backup. Oh, somebody asked, no, I mean meningitis cause. Yeah, the most common cause of meningitis in children, it is Strep pneumonia, yes. Yep. But in a newborn, it is a galacticus, if that's what you mean. So, the next thing I'm going to speak about is this. So, you can see that Viridans is in the same sketch, and they mention a group, it's a gram-positive alpha hemolytic cocci. When I say something is alpha hemolytic, which color it will give? A green, and what other color it can give as well, except a green? Brown, yeah? A green brownish color. They do this. So, okay, and it's uptake-chain resistant and bile insoluble, which is super important for you guys because that helps you to differentiate. It's a normal flora of the oropharynx. So when can it disseminate into your circulation? When do you think it can disseminate into your circulation? It's located inside of your mouth. So it must be when you have cuts inside of your mouth. When do you have cuts inside of your mouth? Dental procedures, exactly. So, very dense group Streptococci is a gram-positive alpha hemolytic cocci, uptake-chain resistant and bile insoluble. It's a normal flora of the oropharynx, okay? So Streptococcus mutans and basically Streptococcus mites, and now they don't tell you very dense anymore. They know that you know it. So they are starting to use these words, okay? Such as mutans, mites, sanguinos. They can lead to dental caries. What are these dental caries? Basically, let me show you. It's quite interesting actually because some people are susceptible to dental caries. They take really good care of their teeth, but still they get plenty of caries. Other people who take horrible care of their teeth don't get dental caries because their immunity is just different. So this is dental caries. This is caused by viridans, yeah? And when you do, well, basically tooth extraction or some dental procedure, you can introduce this bacteria to the circulation, and it's most likely to affect which heart valve, guys? Which heart valve is most likely to be affected? The mitral valve. Absolutely correct. Good. So the next thing, yeah, strep sanguinos make dextrans, and this dextrans bind to fibrin platelet aggregates on a damaged heart valve, which can lead to subacute bacterial endocarditis. First of all, I want to show you this dextran. Dextran is a form of sugar, basically. It's a form of glycogen, to be more exact. And in the sketchy, they give it as like cards. They show it as cards. So you can see this guy, he's the viridans, he has this dextrans, yeah? So, yeah, very dense group strep live in the mouth, but they are not afraid of the chin, uptake-chain resistant. Sanguinos in Latin, sanguinos, the word means blood, okay? So when we say strep sanguinos, it is the one that goes to the blood, which can reach the what? The heart. As I told you guys, it affects which heart valve, the damaged or the normal one? Damaged one, only the damaged one. Okay, so now we'll take our last break for today. We will come back, we'll finish up this, and then we'll finish up all of this page, and then I want to speak just about Bacillus cereus, and then I will call it off with you guys. And tomorrow, I want you to watch until tomorrow the rest of all of the videos for the gram positive, and also I want you to do the mycobacteria, okay? So that's tomorrow's task. So for today, let's take a break for 10 minutes, come back, finish this up, and see, and after that, finish up what we need to finish up. See you in 10 minutes, guys. Hello everybody, welcome back. So let's finish this up. Okay, so now we are going to speak about Streptococcus Biogenes, also called the group A strep. So first thing first, is it catalase positive or negative? Regarding tomorrow, we do not have a class. Yes, it's negative, yes. It's a gram-positive cocci, and cocci will be in chain. Group A Streptococcus, yeah. Biogenic, what does that mean? It means that it can lead to multiple locally bacterial problem. For example, pharyngitis, cellulitis, impetigo, honey-crusted lesion, and erysipelas. So one of the most important thing actually is erysipelas. The reason it is important that it's really common, like it's ridiculously common. You will see it in your career, and let me show it to you. You must be comfortable in differentiating cellulitis from erysipelas. So if you take a look, erysipelas versus cellulitis. Exactly, the clear border. Which one has the clear border? Erysipelas. Erysipelas have a clear border. Cellulitis does not. You cannot tell where it starts and where it ends. Yeah, that's the trick, and that's the way to differentiate between the two. Okay. So the next thing is toxogenic. So it can lead to scarlet fever using a toxin, toxic shock-like syndrome, and necrotizing fasciitis. I wanted you to take a look at necrotizing fasciitis, and you need to be comfortable that necrotizing fasciitis is not only caused by Strep Biogenes. It can be caused by multiple anaerobic infection. It's not only one thing basically. It's many things that can lead to it. Yeah? Finally, the immunological response, rheumatic fever, and glomerulonephritis. Which type of hypersensitivity reaction is rheumatic fever, guys? What about the glomerulonephritis? Yep, glomerulonephritis is a 3. Yep, immune complex. So it's bacillin sensitive, beta hemolytic, beryllidyl arylamidase positive. You are like, well, I know all of them, but what about this PYR? Well, basically, guys, back in the time, they used to use this bacillin. We don't do it anymore, okay? So instead of it, we do PYR. So whatever organism is positive for PYR is the same thing as saying bacillin sensitive. Okay, hyaluronic acid capsule and M protein that inhibit the phagocytosis. Guys, why the M protein resembles which structure in the human body? The myosin, exactly, the myosin. Okay, so antibodies to the M myosin enhances the host defense against the Strep Biogenes, but can raise the risk for rheumatic fever. Diagnosis of Strep Biogenes is via a throat swab, which can be tested with an antigen detection assay. Rapid and in the office, it's like the COVID test, guys. And or cultured on a blood agar. That will take time to come back. It needs 48 hours. Okay, so if we speak about this organism, it can lead to rheumatic fever. It can lead to also what? Glomerulonephritis. It can lead to impetigo, and the impetigo can lead to glomerulonephritis. Now comes my question is, can the impetigo lead to rheumatic fever? Can impetigo lead to rheumatic fever? It cannot. It can only lead to the renal problem, okay? But if we speak about rheumatic fever, it must be due to pharyngitis, scarlet, yep. So the key virulence factor include DNAs. It's not DNA, it's DNAs, anti-DNAs. Anti-erythrogenic exotoxin, streptokinase and streptolysin O, which are all hemolytic. Anti-streptolysin O titers or anti-DNase B antibodies indicate recent Strep Biogenes infection. Yep, so we use this for detection of rheumatic fever, for example. Especially in the clinic, you will notice that we use this anti-streptolysin O all the time. Scarlet fever is a blanching sandpaper-like body rash, strawberry tongue, and circumolar pallor in the setting of a group A streptococcal pharyngitis. You must take a look, guys, about this pallor around the mouth. It's highly characteristic, and when you see it once, it just becomes a second nature of you. So yeah, they have the strawberry tongue. Look at their cheeks. Their cheeks are red, but if you notice around his mouth, it's pale. So that's the circumolar oral pallor. So you can see the child around the mouth is pale, but the face is red, okay? This one as well. Strawberry tongue, red. This is pale. Around his mouth, it's pale. Okay. Good. So the next thing I'm going to speak about is the group B strep. Group B strep. So the group B strep, it's also called Strep galacticus. It's a gram-positive cocci bacitracin resistance, which is represented on a sketchy by using the what? The dog, and the resistance using the helmet of the dog. So it's beta hemolytic, colonizes the vagina. So since it colonizes the vagina, who can get it? The person who comes out from the vagina. Who comes out from the vagina? The newborn, the baby. It can lead to pneumonia and meningitis, also sepsis, mainly in babies. Polysaccharide capsule confers virulence, so it's the polysaccharide capsule that leads to the problem. It produces CAM factor. Guys, I want you to be careful. It's not cyclic A and B. This is not cyclic A and B. The CAM factor, it's named due to the scientist's name. It is not CAM factor. Just let me show you. Yeah, basically just like one virulence factor, but it's not cyclic A and B. Yes, it's this thing. Christine Itkins Munch whatever. It's a name of scientist. It is not again a what? It's not a CAM factor. So let me tell you how we do it. So the first thing to do is you bring this agar and you put on it what? You put a strep of Staph Aureus. And you know what is the Staph Aureus. So you put the Staph Aureus here. Then you get the new bacteria, which could be the Group B, Streptococcus. Then you put it like this, okay? When you put it like this, look at the head. Here it's a flat, it's making 90 degrees. But here it's making an arrow-like structure. This arrow-like structure means it's a positive test, okay? Again, the arrow-like structure, positive test. But no arrows like structure, negative test. Which enlarges the area of hemolysis formed by the Staph Aureus. That's why we have formation of the head of the arrow. Note, CAMB stands for the authors of the test, not the cyclic AMB. It's not cyclic AMB. Heboric test is positive. That was represented by the Hebo on the sketchy. It's BYR negative, which is the same as saying Bacilli resistance. And you screen all pregnant lady between 35 weeks to 37 weeks. At which week does the lady deliver the baby? When the lady normally deliver the baby? 40 weeks. Gestation with rectal and vaginal swab to check that she does not have this. So patient with positive culture need to receive intrapartum penicillin and Bacilli prophylaxis. I have a question. When I say they receive it intrapartum, it means like before the delivery or after the delivery? This is important. Intrapartum is during the delivery. You must give it during the delivery, not after the delivery, not before the delivery. It's during the delivery. Okay, so that's intrapartum penicillin and ampicillin prophylaxis. Remember, it can lead to meningitis in the babies. The next one is Streptococcus bovis. It's a gram-positive cocci, and it colonizes the gut. So we have this is Strep galacticus. Please do not confuse galacticus with a galactia. These are totally different from each other. So this is a galactia, this is galacticus. So galacticus, Strep bovis, it can cause bacteremia and subacute endocarditis. Patient with the Strep bovis endocarditis have increased risk of colon cancer, okay? So bovis in the blood, cancer in the colon. Yep. So the last one that I'm going to explain today, and after that I will call it off, is the Enterococci. So the Enterococci is a gram-positive cocci. Enterococci, Enterococcus fecalis and Enterococcus faecium are normal colonic flora that are penicillin G resistance and can lead to UTI. They also can lead to biliary tract infection and can lead to subacute endocarditis. Mostly they have happen during GI or genitourinary tract procedure. Can you please make a note here? A transurethral prostatectomy. Transurethral prostatectomy. It's something like this. Transurethral prostatectomy. Okay? Please know about it. It is the most common cause of this Enterococcus. They love to ask you about this one. Know it. So, they also tell you here that it is catalase negative, BYR positive, and it's typically non-hemolytic. If it's not hemolytic, is it alpha, beta, or gamma type of hemolysis? It's gamma. Yep, it's gamma. So VRE, vancomycin resistant enterococcus, are an important cause of nosocomial infection, which happens inside of the hospital. Enterococcus are more resistant than Streptococcus, and they can grow up to 6.5 hypertonic solution, and even at bile acids. They can grow over anything. Entero is intestine, fecalis is mean basically feces. Streptococcus and Cocci are berry. Well, that's interesting. So we today spoke about every single cocci that exists in the book that you need to know about. And we spoke about the generalized classification of the gram-positive bacteria. We also spoke about the endotoxin. For the next class, I want you to prepare all of the Rhodes bacteria, including the anthrax, the bacilli, all of them, Clostridia, all of them, the Corynebacteria, all of them, Listeria, Nocardia, Actinomyces, and Mycobacterium, and Leprosy. I want you to prepare this for the next class, and by the next class, hopefully, we'll be done with the gram-positive organisms. So see you guys on the next class, and remember, tomorrow we do not have a class. See you later, guys.